Hello, good afternoon.
Hi, good afternoon, Prof.
Can you hear me?
Yes, clearly.
Hello.
Yes, hear you clearly.
Okay,
Yes, can hear you, Prof.
can we start now?
Yes, Prof.
Can Okay.
Yes.
All right. So welcome everybody for the today's digital morphology sessions. Yeah. This is a postponed session from August. Okay. It will be hosted now from Hospital KL and the Children's Hospital. So may I know which one to start first?
Hi, Prof. I'm Fatin from Hospital Tunku Aziza. I'll be presenting the first case.
Okay, please. Thank you.
May I start, Prof? Tak dengar.
Tu tengok kalau lagging ke apa.
Recording in progress.
Okay. Hello, good morning, everyone. So I will start. I will start with the first case presentation. My case is a 3-year-old girl who presents in February this year. She actually complained of abdominal distension for the past 6 months. But no fever, no other symptoms, but she had a previous history of a left humerus fracture back in June 2022 after a trivial injury. And the serial X-ray shows slow healing of fracture with presence of lytic bone lesion at the site of fracture. So on her presentation at the clinic, she had a stable vital sign, BP of 119/87, heart rate of 125, no fever, temperature 87.1. She was small for age, sweating, warm to touch, no cervical lymph node palpable. She had no any skin or scalp lesion or oral ulcer. Per abdomen, her abdomen is distended with liver HCM palpable below right subcostal margin with splenomegaly palpable 50 cm until suprapubic region, so massive hepatosplenomegaly. She had an imaging studies done which shows liver homogeneously enlarged with a smooth outline and no focal lesion. The spleen is also enlarged, extending up to left iliac fossa region with span measures of 16.17 cm, no focal lesion, with the presence of small splenenculus adjacent to superior pole of spleen. So the impression given by radio team was a 3-year-old with pathological fracture of the left humerus. Ultrasound shows hepatosplenomegaly. Otherwise, no focal lesion or intra-abdominal mass with mild simple ascites. Constellation of findings may represent hematological malignancy of Langerhans cell histiocytosis. So following this diagnosis, clinical team did a bone marrow examination for the investigation. So during the study in February, this patient white blood cell is 6.1, hemoglobin of 8, platelet of 46, MCV 75, FCH 21, hypochromic anemia, with a normal absolute neutrophil count of 2.2, lymphocyte count of 3.4. NRBC is 0.3 with a T count of 2.5. So I will be showing full blood count.
Do you have the value of MCHC?
MCHC is sorry, I didn't put the MCHC level.
Oh, okay. That might be very useful. Whether the person also has got thalassemia or not.
Oh, but she didn't do any age balances or IM study here in our center lah for this patient.
Normally is actually in the printout lah. Yeah. Okay. Then I carry on the blood film.
Okay, so this is the full blood picture of the patient. Okay, the slide shows hypochromic red cells with presence of teardrop cells and also some elliptocytes and vessel cells.
Okay, we take note of that one. No target cells, huh? Yeah, quite a bit of teardrop cells, all right. Wrong age group to think of myelofibrosis, eh?
But patient also had a nucleated RBC occasionally found in the PDF.
Yeah, 3 years old. Yeah, okay. 3 years old. If we got nucleated RBC, okay lah. 8 grams.
But because of the patient history, we also might need to suspect something going on in the marrow as well. Some of this patient had leukoerythroblastic blood film along with the teardrop cell.
Yeah, agree. So definitely bone marrow is indicated. Okay. No, nothing suspicious, huh? No suspicious cells in the circulating blood, huh?
Yeah, I didn't find any blood cells or any abnormal mononuclear cells. Patient had a good ANC count is normal, lymphocyte count is normal, monocyte count is also not increased.
Yeah, I think if it is a hypochromic microcytic picture, definitely with hepatosplenomegaly, thalassemia, or combination of E beta thalassemia is certainly one of the differential diagnosis from the ultrasound suggestion whether it's a LCH or not. Now the ultrasound show you mentioned earlier Guns got bone lytic lesion. How was that done?
Yes.
Is it a skeletal survey or what?
Patient had a fracture in June, which was not investigated here. So I don't have the picture. It was a humerus fracture. It was only detailed in a referral letter. I
see. So you're not able to sort of review the X-ray of the fracture, whether there are lytic lesion. What kind of lytic lesion is it? Is it a lytic lesion that has got a sclerotic margins or without a sclerotic margin? Do we have any knowledge on that?
It was not mentioned. It was just mentioned a lytic lesion in the humerus X-ray at the site of fracture.
Okay. Yeah, I think those information, of course, if you got an X-ray to review, are very useful to contribute to the differential diagnosis. Okay, never mind. Let's carry on. Yeah.
This is the bone. So I move on to bone marrow aspirate for this patient. She is a 3-year-old girl. However, this aspirate does not contain any fragments. So when we go through the slides, there are hardly any megakaryocytes observed. However, we can see some cells that are a bit large, sheer voluminous cytoplasm all around the slide.
Definitely, we can see that even low power.
Okay, these cells are quite large. They are singly nucleated, round, eccentric nucleus with voluminous cytoplasm. So, if the cytoplasm are lightly basophilic, if you can appreciate, there are some striated appearance, fibrillary appearance within the cytoplasm. There are not any hemophagocytic activity seen. And you can see that there are numerous findings of such cells in the bone marrow
Okay,
X-ray.
yes, can visualize that. Can you enlarge one of them? So that we can see the cytoplasmic content. Oh, yes.
Juga tadi yang cantik.
Okay, beautiful. This one is double nuclei. Yeah?
By the two nuclei in one cell.
Doesn't look like Ritz-Sternberg cells, huh? Okay, no lah, it's not lah.
Oh my God, nucleolized. So we have these cells. Otherwise, I did not find any excess of blast in these cells. There are no increase in eosinophilia or plasma cells. They are just normal erythroid precursors and also granulocytic precursors and also lymphocytes.
Okay.
No other abnormal findings, no tumor clump as well. So this, however, we also did an iron stain.
Yeah, very good. Especially got hypochromic microcytic anemia.
Unfortunately, because we don't have fragments, so we forgot.
No iron
No iron.
Oh.
I think we concurrently have iron deficiency. We didn't do any iron study in this case. But the Gaucher cells that I found, like these cells,
oh yes. Oh, can see very nicely.
These are Gaucher cells, but I think maybe this case she's iron deficient. So I think that could be the reason. Maybe why the Gaucher cells doesn't stain for iron in this case.
Okay. So obviously all the fragments have no iron at all. Huh?
Okay. So because of findings, we give the impression of underlying histocytosis to exclude possible LCH or Gaucher cells and to review the trifine biopsy.
Okay, let's look at the trifine biopsy, how they look like. So thinking that is what we call Gaucher's disease. Storage disorder, definitely in a child with hepatosplenomegaly, apart from thalassemia, one have to consider one form of storage disorder. So the question is, what kind of storage disorder we are dealing with? Gaucher is one of them. Have a look. The trifine.
So this is the trifine biopsy. So for a 3-year-old, this is a cellular marrow for a 3-year-old. And we can see some areas of pale staining here with very limited residual hematopoietic cells present.
Oh, yes, still got. Wow, full of them all. Oh.
So we can see that these are the abnormal population of cells which already displays our normal hematopoietic cells to minimum. So these cells are large, voluminous, single nuclei, single eccentric nuclei, and then the cytoplasm also appears striated. Okay, if I read in books, it will say like a crumpled tissue paper pattern for Gaucher's disease. Otherwise, Gaucher's disease are also associated with osteolytic lesion of the bone. But I think here these are just fragmented body trabeculae lah.
Yes.
So we did a few staining to compare, to really distinguish whether this is NCH or not. So first of all, this sheet of cells positive for our LCA stain. So meaning they are hematopoietic cells. We also did CD163 to confirm its origin, which they are positive. So they are from macrophage histiocyte lineage.
Okay, yeah. Yep.
This is S100. So these abnormal sheets of cells are negative for S100. This is CD1A. Also is negative in this case. And we also did BRAF stain. Which is also negative.
Okay, so we are certain that these are macrophages lah.
Yes. And so far, all the staining for ICH patients is negative. Well, we did a pus staining.
Oh, okay.
So this cell is accentuated by the pus stain.
Very rich, wow.
Very deep in like glucose,
cerebrosity. Cerebral.
Oh, okay.
Okay, and in Gaucher also the component in cytoplasm is resistant to diastase. So this is our pus diastase stain. So you can actually see the striated appearance of the cytoplasm from this staining.
This one is more like crumpled tissue lah.
For water cell, I sometimes often find that discussion also. With these findings, we have concluded that Diffuse infiltration are seen by sheets of large cell exhibiting foamy and pale eosinophil cytoplasm with indistinct cytoplasmic border and small vesicular nucleus with conspicuous nucleoli, which stain positive for CD163 and negative for S100 and CD1A. These cells are also stain positive for PAS and resistant for PAS diastase, and BRAF is negative. The three hematopoietic cells are present with scattered reactivity lymphocyte and B lymphocytes. And correlating with the clinical history, such as cystic lesion, hepatosplenomegaly, and hepatopenia, and diffuse marrow infiltration by histiocyte, we give the impression of storage histocytosis, such as Gaucher disease, need to be considered. Unlikely Langerhans cell histocytosis because CD1A and S100 is negative, with no evidence of acute leukemia, lymphoma, or intracellular organism seen in this biopsy. Subsequently, blood test was sent for confirmation in IMR. So we noted that the beta glucosidase is deficient, suggesting that this patient had Gaucher disease. Further investigation of lyso-GL1 level is increased, and also genetic testing shows mutation of GBA gene at codon 1072, confirming that this patient molecularly had Gaucher's disease, Prof.
Yeah, wonderful. So this is very comprehensive documentation of this Gaucher's disease. Very good. Yeah. The only thing that we cannot explain is why is this child 3-year-old has got iron deficiency. Yeah. So that is the other diagnosis that you have to do. You know, in an exam, you miss out. You are so happy you make a diagnosis of Gaucher's disease, but you forgot to jot down that this person got iron deficiency. You lost a lot of marks. Okay. So do we know why the child has got iron deficiency?
No, we're not sure, Prof.
Oh, okay. It's all right then. Yeah.
We will get back to you once we got.
Yeah, it would be interesting to know. Maybe it's a growing child. Yeah, must be very poorly nourished or whatever. Okay, good. Guys, please carry on.
I'll just do some reading for Gaucher's disease. So Gaucher's disease is a rare autosomal recessive hereditary glucosylceramide lipidosis. So it results from glycocerebrosidase locus mutation at chromosome 1q, leading to a markedly decreased glucocerebrosidase enzyme, or also known as beta glucosidase, and accumulation of glucoceramide in the macrophages. So usually diagnosis is made by assays of relevant enzymes such as beta glucocerebrosidase level, and also chitotriocyte, and also glucosylsphingosine level, which is made from alternative pathway of glycosphingolipids metabolism. So, but it can be diagnosed from bone marrow aspirate and refined biopsy, although we can see pseudo-Gaucher cells, which can be seen in other hematological problems such as CML, myeloma, thalassemia, and also AIDS. Clinically, they will present with pathological fracture, hepatomegaly, bone pain, splenomegaly, cytopenia, and also bone marrow infiltration, and osteonecrosis, and also osteopenia. Actually, if we have an X-ray, we can probably see this Allen-Meyer flash deformity, but I don't have any X-ray of this patient. In Gaucher's disease, the mutation of GBA1 gene causes decrease in glucocerebrosidase activity with accumulation of glucocerebroside within the activated macrophage. So this Gaucher cell will release cytokine and chemokine, and also causing reduced osteoblast differentiation and function, reduced bone mineral deposition, and defective bone remodeling, causing decreased bone formation, which leads to bone weakening, cortical thinning, and trabecular resorption. And infiltration of the marrow by Gaucher cells also lead to changes in the medullary microenvironment and compression of intraosseous blood vessel, which cause potential bone infarction and necrosis. So Gaucher cells are usually a large, round or oval cells with small, usually eccentric nucleus with voluminous, weakly basophilic cytoplasm with a wrinkle or fibrillar pattern. And this fibrillar appearance is a result of elongation of lysosome. Gaucher cells also may show extensive erythrophagocytosis. They stain with Sudan black B, PAS stain, and SE trap, and iron stain may be positive. There is also an increase in foamy macrophages. They can appear in the bone marrow as isolated or in clumps or sheets. The cytoplasm is likened to a watered silk or crumpled tissue paper, and the fibrillar pattern are accentuated by pus staining, which are also resistant to diastase. There may be an increase in reticulin and collagen deposition, and they are positive for CD68 and also CD163 lah. So in comparing Gaucher to Langerhans cell histiocytosis, Gaucher is an inherited sphingolipidosis secondary to mutation of GBA1 gene causing beta glucocerebrosidase deficiency. However, in Langerhans cell, there is actually a clonal proliferation of Langerhans cell, which is a multisystemic disease. Both can occur at young age with body lesion and massive hepatosplenomegaly. However, in Langerhans cell, they will usually have extranodal involvement. Most commonly is bone and skin lesion. There is no abnormal enzyme activity in Langerhans cell histiocytosis, but in Gaucher you can test for beta glucocerebrosidase deficiency with increased level of ketotrioxide. Morphologically in Gaucher, there are large round and oval cell with small eccentric nucleus and voluminous weakly cytoplasm with a wrinkled pattern. They are positive for pus and also acid phosphatase. However, in LCH, the LCH, you usually see the histiocyte to have prominent nuclear groove with admixed with reactive cells such as eosinophils, and they will be positive for 1A, Langerhans S100, and BRAF is positive in 50% of cases. That will be all from me. These are my references.
Wow, thank you very much for a very comprehensive summary of the Gaucher's disease and also the differential diagnosis, which we need to consider in this case, Langerhans cell histiocytosis. But I want to point out certain points which are very interesting for us to also refresh our memory. Just now you mentioned, the one thing, do you know the inheritance of this case? Wonder whether it's a family history or not?
This patient does, from the history, there was no family history of hematological malignancy in this patient.
Oh, no, they don't know whether their family member got anybody who has got hepatosplenomegaly no. Also.
Oh, they don't. Maybe because this is autosomal recessive, so.
Yeah, maybe. Because this is inherited, is supposed to be autosomal recessive. So there might be a possibility they, in a family sibling, don't know whether they look out for it lah. Yeah, that's one point. Now, the other point is you also highlighted some of the so-called cytochemistry. Remember, you look at the slide earlier on, you tell us about the cytochemistry in terms of PAS, positive, Sudan beet black. These are all old stain, which you don't do nowadays, but quite interesting to, you have mentioned it. And then obviously, we also quite good to sort of refresh our memory, right? In this case, of course, you have done PAS and turned out to be positive. Yeah. And obviously, because this is a histiocyte, which anyway, you show the marker for histiocyte, which is in the old days, when we don't have all those, markers, we used to do non-specific esterases, which shows histiocytes property. Now, there's another indication here, very interesting, the TRAP, tartrate-resistant acid phosphatase. Yeah. So if you see, cells like this, which are tartrate-resistant alkaline phosphatase, the other one possible differential diagnosis, obviously, is not in this case for TRAP-positive cells, hairy cell leukemia, for example. Yeah. Okay, so these are just interesting point in your review of literature. So I think very, very useful altogether. Okay. Maybe we will open the case for participants. Anybody seen similar case? Yeah. Okay. I think all right. I think thank you very much for the presentation. Beautifully done, and very good for us to revise, which is off and on periodically we will encounter cases of this. Inherited disorders. Okay, now we move on to the next one. Will be HKL, right?
Yes, Prof. Can you hear me?
Can. Can, yes, please.
Okay, I'm Umaira, Prof. MPAT student year 2 from UPM and currently doing
Okay.
my campus training in HKL.
Okay, good, good. Very happy to meet
So,
you.
I
Thank you.
will
Yeah.
so I will be sharing a case. Can you all see the slides? Yeah, and
Yes. Yeah,
it
you
is
can go
moving,
full
right?
screen.
Okay, and it is moving, right? Okay.
Yes. Thank you.
So this, okay, I will start now. This is a case of a 47-year-old Iban lady. We've known a previous medical illness previously, and currently she presented to HKL with right cheek swelling for 3 months duration. It is also associated with pain and bleeding from the swelling for about 1 week prior coming to here. And she also complained of significant loss of weight. Actually, in May 2023, sorry, she presented at our center in July 2023. So initially, she had sought for the medical intention in May 2023 in Sarawak, but however, failed attempted biopsy at that time. She come to here to sought for a second opinion. However, physical examination, apart from the swelling from the right cheek, no other organomegaly or lymphadenopathy. So from the investigation at presentation in our center, noted it is severe normochromic normocytic anemia with normal differential, normal total white cell and differential count with no thrombocytopenia. It was normal. RP, renal profile, urea and creatinine is normal. With LFT, we can see they are hyperparaprotein with total protein of 92 and hypoalbuminemia and reverse AG ratio. You can see that corrected calcium here is a bit elevated, 2.67 at the presentation. So from so they did CT scan, which was done in Sarawak, not in our center. They noted there is a right masticator mass consists of hypervascular soft tissue lesion with bony destruction involving right mandible, lateral wall of the right orbit, causing local mass effect and adjacent muscular infiltration. Sorry. Okay, I'm trying to find my laser. Okay. So there are also bony destruction of the ramus, angle of right mandible, and the mass also extending into the right middle cranial fossa, abutting the right temporal lobe. There are also extensive lytic lesion reported as this is a CECT TAP scan. But however, upon receiving our bone marrow trephine specimen, we didn't we will not acknowledge for this extensive lytic lesion reported from the CECT TAP scan. So, further investigation done in HKL with incisional biopsy of the right cheek swelling in July. They noted intraoperatively, they noted right buccal mass about 8 by 8 centimeter with contact bleeding, with impression of bleeding right masticator mass to rule out malignancy, arteriovenous malformation and vascular anomalies. So for the HPE of the incisional biopsy, let me show you all on the findings because I think it will benefit us looking at this surgical specimen. But let's take some look on this specimen. Okay. This is buccal mucosa. Okay, from the low power first. As we can see here, this actually the first layer is stratified squamous epithelium with if we can see there is ulceration there. The red one indicates there are ulceration there. But when we go deeper, oh, okay. Okay, good. All right, better then. Okay. When we go deeper to the subepithelial stroma, we can see there are diffuse proliferation of these neoplastic cells. Okay, I will make it brighter. Okay. All right. Um. Okay. These cells, which exhibit, so yeah, I'm
Need to have
adjusting
more
the.
light. Cannot see. More light.
Oh, more lights. Okay, okay.
Yeah.
Okay. This is
Okay,
the
great.
maximum can be.
Oh, all right, all right. Can
Okay.
see now, can see now. Yeah.
Okay. Um. Maybe I'll try to add more light from here.
Okay,
Okay.
even better.
Yes.
Beautiful.
Okay. We can see here that the cells diffusely infiltrate with which is large in size, and then there are nuclear pleomorphism with prominent nucleolus here, like here, very prominent nucleolus, and then um, they are also having scanty to moderate rim of pale eosinophilic cytoplasm.
Yeah.
Okay. All right.
Interesting is the mitotic figures. Can see a lot of mitotic figures.
Yes, easily seen, yeah, the mitotic
Yes,
figures.
that's right.
And
You can see
then,
there in the down below in the corner, left hand corner there, this in the cells in division in telophase.
this one.
Yeah,
Oops. How to?
yeah, that's right.
I
Of
don't,
course, there are many
not sure how
other
to zoom. Okay.
anaphase. Yeah,
Yeah, this one, kan?
correct.
And
Yes, so
then we
many.
can see also, if we can appreciate, there are also cells that are having perinuclear halo.
Mm.
Tekan tekan. Oh, okay. All right. So like these cells, um, there are abundant cytoplasm, a bit eccentric with perinuclear halo, if you can appreciate that.
Yeah,
And
can. Nucleoli,
yes,
nucleolus, prominent nucleolus,
yeah,
plasmacytoid appearance, definitely. Yep.
yeah, yep. And further IAC study shows these cells are CD138 positive with MUM1 positive and LCA heterogeneous positivity with kappa light chain restriction.
Oh,
And
okay.
Ki67 is about 50%, which is high.
Yeah. Explain why
And
so
these
many
cells,
mitotic figure. Mm.
yeah, and these cells are negative for CD20, CD3,
Okay.
ALK, and HSV8. I will share lah further why this IHC stain were done for this patient.
Okay.
Okay, so let's get back to the hematocyte. Okay, so our differential, so at that point of time, the differential diagnosis could be neoplasm with plasmablastic differentiation, could be either extraosseous plasmacytoma, which is at that the right buccal mucosa only, or it is part of the infiltrate of the plasma cell myeloma, or it can be plasmablastic lymphoma. Okay, so at that time, BMAT was done to rule out bone marrow involvement. Um, so I will show you all first on the full blood picture. Okay.
Not seen yet.
Not seen
Not
yet.
seen yet.
Oh, maybe sebab aku buat picture kan. Hmm. Okay. Okay.
Okay.
All right. If we can appreciate in the low power.
Low power, immediately you can see ruler formation.
Yeah, I want to see that. Yeah, there are ruler formations here and there. Okay. And there are single nucleotide scene, but it's okay. I will show that. But I want to share a few of the cells that we found in the peripheral blood film.
Oh, okay. So you can see it also in the peripheral blood, huh?
It might be the same cells that present in the right buccal mucosa. Okay. Terangkan.
Oh, yeah. Interesting.
Okay. But in here, they are more basophilic, right?
Yeah, more basophilic. Is that a Gaucher apparatus? Is that a pale area in the cytoplasm? Doesn't look like a Gaucher apparatus. I suppose
Probably.
it can be. Can be, yeah.
Can be. And then another cells, there are few cells. We counted of total 2%. That's present in the peripheral blood. Okay.
Yeah, you got it.
Yeah.
Oh, this one doesn't look like plasma cell. Doesn't look like.
Yeah. Very prominent nucleoli.
Yeah. The Gaucher also can see.
It is not eccentric. The nucleus
That's
is not
right.
eccentric. Rather than the upper
Yeah.
cell is more eccentric with like oval, like lymphoplasmacytoid cells, right?
Yeah. So this one, the lower one, looks like more like plasmablast, if you call it.
Also, there is another one cell. Actually, I want to say this is more plasma cells looking, normal plasma cells. More mature. Oh no, this one also plastic looking juga. Okay.
Yeah. Okay, definitely you got circulating plasmacytoid cell. If you're not sure, then they're all cytoid.
Yeah. Okay. Then let's take a look on the spirit.
There's no leukohydroblastic, just some circulating cell.
Only NRBC found in the peripheral smear. Even the count also all are within differential normal count. Immature granulocyte cannot be seen in the peripheral smear. No LE picture.
Yeah. Okay.
So let's go. Okay, this is definitely a for 46 years old.
Oh, it's packed.
Yeah.
Hardly any fat cells.
Yep. Very markedly hypercellular. And markedly hypercellular trails juga. Alright. These are the cells that present. Okay. These are the cells that present in the.
Wow. Full of them, huh?
Majority of the cells are them.
Yeah. Different type.
They are of heterogeneous.
Yeah, it is heterogeneous.
They are more plastic, few of plastic looking cells, or we can say that it is a plasmablast, like the one.
Yeah, some you say is plasma blast, others are you probably say no, cannot lah. Doesn't look like a blast.
But we
That
were
one is a
introduced
mitotic
also.
figure.
We were
Next
introduced
one is
also to a term by our histopathologists of a term of asynchronous form, in which they have a prominent nucleoli, but they have already abundant cytoplasm with perinuclear Hopf. Probably like like this one. They are having prominent nucleoli, but the cytoplasm already maturing, which we call as asynchronous form. And while the earlier one I showed you all is the plasma blast, while the rest of them are mature plasma cells. Okay.
okay.
All right. So if we go to the trephine biopsy.
All right. We'll see how they look like in a trephine.
Whether they are the same in the Gaucher mucosa or not, right?
Yeah.
Okay.
So definitely there is
okay.
infiltration also lah. Not only in the Gaucher mucosa mass, but also in the bone marrow. Now let's see how extensive it is in the trephine.
Okay, this is a hypocellular marrow for 46 years old. Okay, this area, I will focus on this area. They are, okay, it's a bit dark, right? Okay. All right. You can see here the cells are mainly showing immature, immature, I would say plasma cells with a prominent nucleoli. And for example, I will show you these cells. They are they are very prominent nucleoli with lesser abundant cytoplasm, which we can safely say it is a plasmablast, while the other maybe looks like this one. They are also prominent nucleoli, but they have already abundant cytoplasm and perinuclear halo. So this is the types of the cells that we call as asynchronous form, and there are areas actually showing us the more mature plasma cells, which is
there are actually a mixture more matured plasma cell as well. Wonder there's also mixed with some lymphocytes or not. Huh? But anyway, we'll see it later.
Okay. We have searched thoroughly. No plasma aggregates or nodules seen in here. Okay, this is more mature one, a smaller size like that. Okay, so for the IHC study,
okay,
these cells, as expected, they are okay. This is 138.
Okay, 138.
Yep. So it's positive for 138. Okay. And then for mom one, just now 138, we stand for the cytoplasm. For MUM1, we stand for the nucleus of the plasma cells. They are also diffusely positive for these cells.
Okay.
And then for CD56,
56.
also,
Hmm.
yep, CD56.
Hmm.
Diffusely positive
Also
also.
positive, huh? Hmm.
Okay, and CD117, part of the aberrancy. So we can see that some of these cells are positive for CD117, part of the aberrant marker. Kappa and lambda, whether it is clonal or obviously clonal.
Okay.
Okay, this is kappa light chain, and
Okay.
this is lambda.
Oh, not taking up.
Not at all.
Scattered lah.
Or maybe, yeah, the remaining cells.
So doesn't stain the tumor cells. Yeah.
Yep.
Okay. So obviously it is clonal. What about the B markers?
B marker, CD20.
CD20. Let's see.
Where is my sample? Okay, here. Okay. All are negative for CD20.
Negative, huh? Wow. That means even the normal B cells also not there.
Present, not noticeable.
Wow.
Very scattered.
Occasional, very
occasional.
small number, yeah. So the residual B cells, okay. CD19, 79 alpha got or not? PEX?
79 alpha, yes. This CD17 alpha.
Okay.
Also
Some
negative.
residual B cells. So here and there.
Yeah.
Okay.
Not the aggregates, right?
Not in aggregate, yeah.
We also do CD30.
CD30, okay. Yeah.
CD30 is negative in this case.
Okay. So it's not Hodgkin, it's not anaplastic large cell lymphoma. Okay.
Yep. T67. T67. Yeah.
Okay. Very strong. Huh?
Yep. We reported about 50 to 60%.
Yeah.
Not
surprised.
Okay. Another one is EBER.
EBER, very important.
Okay, this is our cells. Okay, let's take a look on the control first.
What's color supposed to be?
It is supposed to be this
black,
blue, black or blue. Bluish.
Okay. Deep bluish.
Deep bluish, yeah.
Okay. Yeah. Almost black already. Okay. All right. This is a control, right?
Yes, this is our control.
Control. Let's see.
Let's see our patients. None of the cells.
Not apparent. Huh?
Yeah, none of the cells pick up the stain. Yep. So it is negative.
All right.
So which was initially pending in the oral mucosa specimen, now also reported as negative for this Epstein-Barr encoded region inside to hybridization. Okay, what else missing? I think that's all. So let's get back to
your differential diagnosis. Which one is which?
Okay. Okay, this is the immunophenotyping of the
Oh, okay.
cells. Also, we can see. Okay, this is the population of our interest, CD45 dim with moderate size scattered, and CD38 positive, CD13 positive, and expressing kappa light chain only, and
Okay, yeah.
CD56 positive, and beta 2 microglobin.
Oh, beta
Which
2
is not-
microglobin. Oh, okay.
Mm-mm.
Good.
Which is of total 46% of the nucleated cells of these clonal cells.
All right, yeah.
Mm-mm.
Mm.
So this is my differential for this patient coming with plasmacytic or plasmablastic nucleism in the extraosseous location. It could be either primary extraosseous plasmacytoma alone, or is it part of the extraosseous infiltrates of the plasma myeloma, or it could be plasmablastic lymphoma, or any lymphoma, actually any lymphoma with plasmablastic differentiation.
So you are thinking here you got primary extraosseous plasmacytoma.
Mhm.
Oh, now it cannot be
But
that. Okay.
it was initially,
Oh,
but
okay.
when we are looking at the bone marrow, it's not. It is more towards the extraosseous infiltrates of plasma myeloma,
Okay.
but and it is not plasmablastic lymphoma. Why? Maybe I can.
When you say plasma cell myeloma, you mean is plastic myeloma, is it?
Actually, from the tree find, we can say it is plasmablastic variant of the plasma cell myeloma, because
Okay.
most of the cells are the immature one, which shows prominent nucleoli, right? Mm. So okay, maybe a bit
Oh, did we look at
education.
result of paraprotein finding?
Yeah, it was later revealed
Or only
that
later?
it was okay. Maybe I can go through the. It was later revealed, which is in the end of the July in the month,
Okay.
that patient is having IgG kappa paraproteinemia with quantification of 59.2 with excess
Okay.
kappa that change. There is also
Yeah.
immunofluorescence. Also in the urine there is paraproteinuria.
Okay. Yeah.
And
Okay.
serum free light chain shows free light chain kappa of more than 100 milligram per liter to 135. And for the investigation, this patient is non-reactive for Hep B, Hep C, or HIV. And the beta 2 micro, sorry, it's micro, actually microglobulin is 6.78. This is elevated.
Yeah, very high.
Yep. So maybe I will share a bit on these three. Um, from the presentation, what are our differential diagnosis? So for the primary extraosseous plasmacytoma, it is the localized plasma cells arises in tissues other than the bone marrow, or other than the bone and no evidence of the bone marrow. While the extraosseous infiltrate of plasma myeloma, it is a manifestation of advanced plasma cell myeloma. And for plasmablastic lymphoma, it is a very aggressive lymphoma, which resemble plasmablast and frequently associated with HIV or immunocompromised patient or elderly with presumptive immunosenescence. And up to 70%, they are associated with EBV infection, which in this case, the EBV is negative, which we can safely exclude this diagnosis, plasmablastic lymphoma. And then for the location, why it was initially thought to be plasmablastic lymphoma, because of the presentation in the oral cavity. While the plasmacytoma usually in the mucus also can be in the oral cavity and other sites like GI tract, lymph node, bladder, breast, thyroid, testis, parotid gland, skin, or CNS. while the extraosseous infiltrate of plasma myeloma can be any site. And the presentation is mainly tumor mass related symptoms, and also this patient, I remember following this patient to the hospital Ampang punya notes, it mentioned that this patient also complained of odinophagia. But apart from this, the presentation for differential diagnosis of extraosseous infiltrate of plasma cell myeloma, we must ascertain the myeloma defining events, which is the CRAB and the basically the CRAB lah kan. While for the plasmacytoma and plasmablastic lymphoma, absence of myeloma defining events, lytic lesion can be presented in all of these diagnosis, but more common in the plasma cell myeloma and part of the myeloma defining events, while they are rare in the plasmacytoma or plasmablastic lymphoma. Paraprotein, yes, in plasmacytoma we can have paraprotein about 20% of cases, but usually low level. And in the plasmablastic lymphoma also we can have, but rarely, and case reported usually less than 20 gram per liter. For this patient, we have 56 gram per liter. And then for the bone marrow involvement, for the plasmacytoma, no involvement, and it happens when disease progress to the plasma myeloma, or there are also a classification of minimal bone marrow involvement in plasmacytoma. It is usually less than 10%, while in plasmablastic lymphoma, up to 65% in a HIV patient can have this lymphoma infiltrate the bone marrow. So for the morphology, plasmacytoma usually mature plasma cells. For the extraosseous infiltrate of the plasma cell myeloma, as we can see just now from our 3-point biopsy and also aspirate, it can be plasma cells or plasmablastic. And in the cells, in the tissue, more frequently they show cellular atypia or blastic features in advanced disease. While the plasmablastic lymphoma, mostly they are plasmablastic differentiation with very occasional plasma cell component. Immunophenotype, they are almost similar. They are similar plasma cell. They express similar plasma cell markers, except that for the plasmablastic lymphoma, usually CD56 is about positive in about 10 to 30% of cases, and it can be negative in oral mucosal type only. And EMA and CD30 is frequently expressed, and K67, which is usually very high, more than 90%. But for this patient, in the oral sample and also in the 3-point, about 50 to 60%. So this is another algorithm I found in one of the journal for the plasmablastic neoplasm. We can differentiate them from EBER and HSV8, stain, and also ALK. If they are negative for all, with the suspicious lymphadenopathy or oral mass, so if it present, we can say that is a plasmablastic lymphoma. And if there are myeloma defining event in which present in this case, we can say it is plasma cell neoplasm or multiple myeloma. So for the molecular, for the plasmacytoma, absence of the T11-14 translocation and MYC rearrangement. And for the plasmablastic lymphoma, absence of the plasma cell type translocation, and about 50% of cases present with MYC rearrangement. And for the EBV infection, about 50 to 75% present in plasmablastic lymphoma, while in the plasmacytoma and plasma cell myeloma, rare or absence. And as we all know that plasmacytoma is it's not a good disease, but the outcome is better than other. It is good outcome with 70% of patients having disease free at 10 years duration. And for the extraosseous infiltrate of the plasma cell myeloma and plasmablastic lymphoma, they are both poor prognosis. So the final diagnosis is IgG kappa myeloma with extra osseous infiltration. And this is my final slide, my take-home message. This is the advanced manifestation of plasma cell myeloma that can mistakenly interpret as plasmablastic lymphoma. So it is well justified to expand the ISC study for this type of morphology to exclude lymphoma with plasmablastic differentiation, such as CD30, IMA, ALK, HIV-8, and EBL in situ hybridization. However, in this case, we didn't proceed further as the tissue sample already done for this IC studies. Yeah, I think that's all.
Okay,
Thank you.
okay, thank you for a beautiful, very well worked out case. I think at the end of the day, the crucial problem here is actually the distinction between plasmablastic lymphoma and plasmablastic myeloma. This is often being, in the literature. If you look at the literature, you'll find that there are cases where we reported that this is a diagnostic challenge between the two. But I think you have correctly summarized all the things to help, to distinguish between these two. And I'm convinced, like what you have presented, this is more of a plasmablastic myeloma rather than a lymphoma. I think it's important because this one go to the clinician. They have to say whether I want to use treat it as a myeloma or treat it as a lymphoma, because the approach is totally different. Very beautifully worked out case. So I suggest maybe you should publish this one, or
my specialist also asked the same thing.
Yeah, so welcome to submit it to Malaysian Journal of Pathology, which now in Scopus is already got a site score of 3.0, very high, consider a high impact journal. Yeah, also going into tier 2 already. Yeah. Yeah, I think the same thing. So thank you very much. I think today we have actually got two interesting cases. One from a kiddie, one and now from a 47-year-old lady, and both cases are very well worked out, and I think both cases also should be submitted for publication. I think the Gaucher is not a common problem, but I think the whole case was very well done, and carefully studied to document and prove that it is a Gaucher's disease. All right. So similarly, the plastic myeloma is also very well done. So thank you very much. I think let's see whether any comment from the participant. Yeah. If not, then I must say that we have very good take-home messages for both cases. We learned a lot today. So thank you for the team in HKL and the Children's Hospital. All right. Bye-bye.
Okay. Thank you so much, Prof.